start on time. We're going to learn something about treating sleep apnea with some dental devices. And Guy and I have done quite a few of these over the years, and hopefully you'll learn something, whether you've done just a couple or you've done a couple hundred. Maybe I think you'll probably learn something tonight.
Got quite a few people logging on. So as you all can see, your mics are muted because with this number of people, we're not going to be able to leave the mics open, at least at first. If you have questions, type them into the question box and we'll answer them as we go. In the question, not the chat. Make sure you use the question. That's the better one to type into. And we will we'll get right to your answers as quick as we possibly can. So
how's your NCAA bracket doing, Guy?
It's not well because I had Kentucky and Florida. Kentucky for myself and Florida for my wife, who's a Florida fan. And no, so it's not good. Kentucky's game, as you probably saw, was extremely close. But yeah, so I have none left in the Final Four. How about yourself?
I have one.
Yeah. Okay. We do a pool here each year. If my dad actually started years ago, and they still carry it on after he's passed away. But it's been a strange year because usually, it's a lot of people in it. But still is exciting. We had an exciting game, so let's.
Yeah. Yeah, you know what the odds are of getting a perfect bracket?
No, but I know that you can get like $1 million for it. No one's ever collected it that I know of. Is that right?
That was Warren Buffett's deal, was $1 million to his employee. Yeah. All they had to do was get the first round right, just the first round.
That's how hard it is.
The odds for that are like 1 in 9 million, and the odds for a perfect bracket are like 1 in 5 quintillion or something like that.
Yeah. Well, I'm not real good at investing, as you've heard, and so if you want a team to lose, just let me bet on them. That's the surefire way to get to change the odds. Hey, it's 8 o'clock, man. Let's get going. We've got a lot to get going to go through here today, with treating 99% of your patients with these 4 devices, and I think we should get to it. What do you think, Rich?
Yeah, let's go. Thank you guys for joining us. We see a lot of people logging on now. You are muted. Use the question box. That's the best way to do questions. Guy's going to be running the PowerPoint, and he and I will both be answering some questions along with Jason. So that's me on the right, and my partner Guy on the left. We co-founded Dental Sleep Solutions, and we've been doing this a lot of years. So,
right. We've been doing a lot of years, and we've been working with NDX, National DENTEX Labs, for many years. They have supported us, and we've done a lot of courses for them. And you all are likely familiar with some of their products. One you might not be as familiar with if you're somewhat new to dental sleep is their dorsal design, and it's called the ClearDream, and it's one of the devices that I choose to wear most nights myself. It's a really rigid design because it's made out of invested acrylics. They don't just powder and salt and pepper it. They actually make a wax mold and make this injected molded dorsal design that holds up really well, can be made very thin. And for $305, I can honestly say it's one of the best values on the market. As you all know, the NTI is another device we talk about. We're not talking about TMD today, but we also have to know a little bit about TMD to be involved in sleep at times, and we certainly still do a ton of NTIs for patients who are clenching, and we're trying to get their muscles calm down sometimes before we begin dental sleep medicine treatment. So, and last partner I want to mention here is our partners with KKGI. Instrumentarium is the 3D unit that I use. I have CBCT in my office, and we'll probably do other webinars we have in the past on how we use those in our offices. But if you're going to consider getting a cone beam for implants or some other reason, getting one that allows you to see the airway at minimal exposure, I think you've got to give a look at this OP300 that I have. I really like the unit. So we appreciate their sponsorship of our programs as well. And this is what we do, right, Rich? This is the DS3 experience.
Yeah, Guy and I met many years ago, and we, really started this whole thing with just how can we help dentists do this in their practice. I mean, that really is what we're all about. We talk about the 4 pillars: screening, testing, treating, and billing. And tonight we're going to talk about treating, with devices.
Yes, and if you need help after our webinar, and you want to kind of address some of your issues, and you want a consultation with one of our experts, just type in demo any time throughout the night, and we'll meet with you. You'll talk to our team who have years and years of dental sleep medicine experience, and they can help gauge where you are in dental sleep and help you understand the hurdles better, and some solutions, some real good solutions to helping you over those. And if you want to look at our system, how we do that, we'd love that opportunity. So just type in demo into the question box at any point, and you'll have that opportunity to meet with one of our specialists. Jody or Brandy will get right back with you if you type that in. Also, our courses, we do hands-on courses, and I will put this up at the end too, but I want to mention it at the beginning. All throughout the country. I'm actually going to Kalamazoo tomorrow morning at 6 o'clock. I got to get picked up to go to the airport, and we teach courses from Hawaii to Michigan, and we really have some of the best ratings for these courses because we teach you how you do this in your own offices. And if you are interested in attending one of these courses, it doesn't hurt you just to type in course tonight, because Jody and Brandy will get in touch with you tomorrow, and they'll give you a nice discount on one of our courses coming up as well. So that's it for what we do. We'll mention it again as we go throughout, but Rich already mentioned the 4 pillars. This is, if you can get a solution for these, a system for these, and accountability in your office to screen, test, treat, and bill for dental sleep medicine, there's not much to it. The treatment part is what we're going to talk about today, in particular the 4 devices that we do. So again, this is what we do in our business. So Rich, I think I threw this slide in here because I think this is what really changed dental sleep for me. And I know this may be repeat for some people, but I think it's important for us to understand, how we've come a long way in the last 17 years or so that you and I have been doing this.
Yeah, you talk about that as the day the earth shook, and when we talk about, back in the day when we first got started doing this, we didn't have a code for it. We didn't have a medical code. Medical people, everybody asked about it. Nobody knew, hey, do these things really work? The physicians in our community are a little bit in the blind still. But in 2006, they came out and said, hey, you can use these as a first line of therapy for mild to moderate sleep apnea. And they've since updated those practice parameters in 2015. But the thing is here, nobody is asking, do dental devices work anymore? And if they are asking that, they've been on a trip for the last decade. These things do work. When you look at this, and the updated practice parameters had almost 500 randomized controlled trial studies in there, and they looked at different questions, and they were really comparing CPAP and dental devices as well as dental devices. So there's the skinny of it right there. Those 4 questions, we could talk about that for an hour.
Right.
They do talk about a qualified dentist being somebody that has 25 hours of CE. So I'm not sure that makes you qualified, but at least it gives you a start. What do we say, Guy? Go back to your office and start making devices.
Start doing it.
Yeah.
That's what will qualify you. You'll learn how to do this. And I think the take-home message are dental devices work. They're recommended in all patients as an option for apnea, and the other option being CPAP. And the more mild to moderate the case, the better they work. And insurance companies cover these now, and it's not a question anymore, do they work? They work. And in many cases, better than CPAP. Some not as well, but overall, they're a very viable option. And it's a huge market. We could talk for the whole hour about that, but we're not going to. But just as a preface to getting going, if you're sitting in your office thinking, do I really want to get involved in this? If you want to help your patients live better, live longer, and increase your financial income for you and your team, then there's really no reason not to, because it's one of the most enjoyable things you can do in your practice. So how are we going to talk about this today? We're going to talk about the 4 devices, and we want to talk about them, how we select them. But one of the questions that always comes up is, where do you take the bite? So we're going to talk briefly about that first, the criteria for the device selections, the 4 devices that I would say 99% is a maybe even conservative. That's almost 100% in my practice that we do these. And then after we give them the device, what do we do? We'll briefly talk about that as well today. So taking the protrusive bite. Rich, how'd you do the very first one? You told me you told how you used to do this years ago was tongue gauges or pencils or something. I think you told me you used. Are you there? I've lost Rich here, so I'm assuming everyone can still hear me. There they are.
Sorry, guys. My phone was ringing in the house here, so I had to turn it off. But yeah, it was, hand me 3 of those tongue depressors over there, and we'll, we'll take one. But now you can be a little more sophisticated. They have the Pro gauge out. Used to be called the Tap gauge and the George gauge. There's the Andrew gauge, and there's Airway metrics. There's all kinds of systems that you can use for doing this. And the 2 probably most popular are the George gauge and the Tap gauge. And your top teeth go in one groove, your bottom teeth go in the other groove, and then they have a little sliding scale, and you can just see how far somebody can move their jaw. It's really makes it pretty easy.
Yeah, the goal here is to take it at a forward, comfortable position. So you look from the most retruded to the most protruded, and that'll typically be somewhere to 40 to 60%. One note I want to make: George gauge is on the left, Pro gauge is on the right. It used to be called the Tap gauge. I just noticed our slide has the old name there. So the Pro gauge, Tap gauge, that's the same gauge. They just renamed it a few years ago. So taking the bite, really, there's all kinds of YouTube videos out there. If you have any questions about this, if you want to set up that demo with our I'm going to go through this because I don't think the sound works on that. We determined, but our member support team, Jody or Brandy can answer and point you in the direction to see some videos on how to do that. So set it to take the bite. You want to take it at a vertical that's enough to make clearance for whatever material you're putting into the patient's mouth. So if it's acrylic, and typically 4 to 4 millimeters or so between the arches is the vertical size that you select. So again, I think the reason most people tuned in today was to decide on, what do we do when our patients fall asleep and this happens, right? How can we help that, and which device helps that the best? Don't you love that? I love that little video, Rich. Isn't it really just tell the whole story?
That's how we make a living,
That's how we make a living. And the truth of the matter is, it's not just as simple as that, is it? I mean, I like these slides because it shows it's more of a 3-dimensional widening of the airway as opposed to an anterior posterior.
You would think that when we move our jaw forward that our airway would get bigger anterior to posterior, and it doesn't. It really gets bigger in the lateral dimension. You can really see that in the area below the the posterior airway space back behind there. So there's a lot of things that work here. There's some nerves and some muscles and some origins and insertions and all kinds of things. But suffice it to say that when we grab a hold of the lower jaw and we move it forward, the airway does get bigger.
Yeah, and if you can see, the right side's moving the jaw forward on sedated patients. The blue's the airway, and just you can see laterally and anterior posteriorly from the left, the right compared to the left, we have a notable increase in our airway. So how do we decide? I think the next slide is the way Rich taught me to do this. We could ask Kramer, but that's probably not going to help a whole lot. Rich taught me to do it this way, and it works most of the time, doesn't it, Rich? That was your advice, I think, to me 17 years ago when I asked you that question.
I think if we just take the 4 devices we're going to talk about, we put them on the wall and we threw one at it. I like to say that you can't make a wrong device, but you can make a better device. We see dentists get so hung up on which device I'm going to make, and just make them one. I mean, but you're going to get some great information here tonight. Use your brain. There are some things you can evaluate, and I think you can end up with a little better outcome if you evaluate the patients and use some of the criteria that we're going to talk about tonight.
I agree, and I think that's to hammer that home. The biggest problem I think Rich and I see, because we teach thousands of dentists how to do this each year, and is the failure to do anything. And go out there and make some devices. You know, even if you got to just do them for cash, make them on your friends and family. And for the most part, it's going to likely work. What we're going to help you with today is fine tuning that and making it better. You're going to have to use your brain some, but we're going to try to minimize that as much as possible and try to help you with this decision process. That's one of the reasons we came up with this device selector that Rich and I spent a lot of time on.
Yeah, and you evaluate, you know, this is what we look at when we're doing that. How big is somebody's tongue? You know, do they brux or not? Are they daytime bruxers? Are they nighttime bruxers? Is their bite shallow? Is it deep? I mean, we go through all of this kind of stuff. And we developed an algorithm in DS3, and you just kind of click a button after you evaluate those things, and it gives you a score of the devices on the right-hand side. And I think, what do you think, Guy? If you take the top 3, 4, 5, you're probably in the ballpark.
Yeah, just don't take the bottom third and you'll be fine. And it's not perfect, but it's certainly, I think it's kind of a nice, almost instructional tool as well for you to start thinking about these devices and why that one rank higher. And it's because of these items we're going to go through as we look at all the, you know, there's really hundreds of devices you can choose from, but the 4 we're going to talk about tonight are, I believe, not only the most common in mine and Rich's office, they're probably the most common across the board. And it starts with a good exam. When we do our exam on our patients, once they've decided to do treatment, you know, I tell the patients there's several purposes here. One of it is we need to look at your airway and document things medically, legally. We need to make sure your teeth are strong enough to hold this. But ultimately, all this exam, at the end of it, we're going to see, you know, we're sizing you up for a device. We're trying to find which device might be the best suited for you in your situation. And at the end of this exam, Mr. Jones, I'm going to show you the device I think is the best for you and why. And you get to agree to that, though. You get to have some say-so. Now, I used to take all 4 of these devices and ask them to pick one. Did you ever done that, Rich?
Of course. Always.
How'd that go?
Yeah.
Did that take a little longer?
Yeah, you know, I guess if it's a male or female, but no, we won't go there.
Yeah.
So, but are we going to go through these one at a time, Guy?
Yes. Yeah, we're going to go through those one at a time, but the point is, as you're looking at the teeth, as you're doing your exam, you're talking to your patient and you're noting these things. We have a really good system for noting them as well to make it easier, because that takes me about under 10 minutes, 5 to 10 minutes, 10 on the high side, to do my exam and take my bite and select the device. Because we've done it before, we have a system for doing it very, very precisely and quickly as you go through this. So think while you're going through here, you need to document the size of the tongue for your medical legal record. Especially if you're billing medical insurance for this, and we need to talk about why we're doing it, why they have apnea, what are their risk factors, and the tongue is one of them. So we're looking at this tongue. Does that tongue look somewhat different than maybe someone else's tongue? How would you describe this, Rich?
I'm just glad I don't drill on lower molars anymore. That's what I would say. I feel sorry for your assistant, has to hold that thing out of the way. She's probably going to need a brace or something before you're done. But you know, the other thing I want to add to that, Guy, is I've found that this kind of creates value as well.
Yeah, absolutely.
Every now and then I have a patient come in, they go, well, you know, my dentist made me one a couple years ago, and I don't think he knew what he was doing. He didn't do any of this stuff. They didn't talk about any of this stuff. They didn't do any of that. So I think sometimes we forget that it really does
absolutely
add value.
It adds value, and it's valuable. I'll even turn that around, because this information we're gathering, we're not just doing it to add value. It's valuable information that adds value to the patient's overall experience. So we're going to look at this tongue, and so, you know, certain devices take up tongue space. Certain devices, we might want to make them taller to make room for those spaces, or less acrylic on the inside. So, you know, we want to look at this tongue. Yeah, it's scalloped. It's a little bit enlarged. It may stick up above the occlusal plane. It may be retracting into opening. So we're looking at these things while we're doing our exam. And of course, we certainly don't want to do a mandibular advancement device without evaluating the TMD. You know, we're going to look for joint and muscle problems.
Yeah, and you can, you know, if you're a TMD guy and you're an expert at this, you've already got your own system. But if you're not, then at a minimum, open and close, open and close. I just kind of palpate the joint. I note crepitus, clicking, popping, opening, closing. But I also ask the patient, you know, I don't hear any crepitus or clicking or popping. Does your jaw ever do that? Oh, you know, sometimes it pops. And one time it even locked open while I was eating a hamburger or something like that. So you always have to ask that question as well as go ahead and do the palpation part.
Right. And what we're trying to find out here is range of motion too. If they can only open a little bit because of a joint problem, then that could change the device we're going to do. And if they have a joint problem, we might want to make sure that the device doesn't put extra pressure on the joint by only hitting in the front, for example. Certain devices only hit in the front. If it's a joint problem, we might want to make sure it hits all the way around, or for sure evenly on the back as we're doing this. And documenting this is important. We're going to put up some slides at the end, and for those of you who just joined us, keep typing in your questions. We'll answer them, and if we have at the end, even if we'll stay on as long as necessary to get all your questions. And if you want to know more about what we do, just type in demo, as we mentioned, and we'll show you how we can do this in your practice as well. But one of the things we also will show at the end is our Dental Sleep Medicine Insider, and I thought we had a really good article in there by Jamison Spencer this month that talked about how, you know, people with joint problems actually benefit oftentimes from these dental devices. But, you know, that may be contrary to what some people think or believe. We just need to document why that is the case. So documenting is important. Muscle problems as well as joint problems need to be looked at, because people who are clinchers and things, we'll show you some pictures in a moment, might be have their own set of issues. Does it matter how many teeth are there, Rich?
Yeah, you got to have a few. You know, I mean, we can make them with no teeth on the top and 4, 5, 6 on the bottom. I have done that before, many times. But you got to have, you know, how many people have their canines and, you know, a molar, you know, on upper and lower? You probably could do it if you had, you know, 4 teeth on top and bottom. But you got to have teeth to do this. You know, how much range of motion? You mentioned that, guy. You know, one of the slides you showed earlier was the NTI. You know, I have on times put somebody in an NTI and done some stretching and some different types of things just to get their mouth open far enough to take an impression, you know, because they were so tight. So you're looking at Mallampati score, you know, how much of the back of their throat can you see? If it's all of it, it's 1. If it's none of it, it's 4. And then whatever's in between there.
Right. And retention. You know, if you decide to come to one of our courses, and again, we'll put those up at the end. And if you're interested to coming to one, just type course and you'll get a discount for attending tonight, by the way. But one of the things I always ask the audience is, do you want these devices to fit tight? And, oh yeah, you always want them to fit tight. Well, can you always make them fit tight? Well, sometimes you can't when you have poor retention. But you know, Rich, there's times where I don't want it to fit tight. I want lower retention. It's kind of a trick question, but sometimes people have really shaky bridge work. So I'll say it looks like something that G.V. Black put in them himself. It might be 100 years old. And do you want this device to fit real tight? Well, sometimes we can't make them fit tight. Sometimes we don't want them to fit tight. And that might affect which device we choose to do as we start talking about the devices, because some of them have to fit tighter to be effective and other ones can fit looser, like you mentioned. One of them a couple of them we can even do on a completely edentulous upper patient. So I think it's real important. And what do you call them? The snaggle teeth there, Rich? Long or crooked teeth, I think you call them. If they're diverging, that could affect what we're doing as well. Yeah,
too tight, you know, too loose. That's one of the hardest things that we do day in and day out for sleep devices. So you do have to, but like I said, you know, sometimes that changes which material we use too. We may use the thermocryl or something like that when we do that. But, you know, we could talk about bruxism for a couple hours here, but, you know, we know that there's awake bruxism and there's sleep bruxism, and about 20% of the population has awake and about 10% have sleep, and then there's a carryover between those two. So sometimes you got to use your brain, though. I mean, right. You know, there is no doubt that if we took everybody that had sleep bruxism and we documented it through EMGs and sleep studies, most of those people have sleep disordered breathing. So there's a very strong correlation between the two.
I got to mention that one of my friends who's been in dentistries and dental implant business sent me an email. I think he might be listening tonight about some new studies that I told him about Bruxism and breakage of implant porcelain and so forth. And his question was, right, does OSA, do people brux their teeth more? Do you think? And I said, I don't think, I know. And this book here that's cited is one of the best reference books in sleep in the world. I mean, it's very well known. You all may not know much about it because you're in dentists, but they're saying that bruxism on apneic patients is 2 to 3 times higher. So that's not Guy and Rich's opinion. That's a fact, at least in the sleep world, and that's a sleep problem. So if you have challenges with bruxism in your patients, you need to start thinking about this. But we might want to know that they do this ahead of time. If they're a big time bruxer and their teeth look like this, and they're I'm gonna go over here to this next slide real quick, Rich. You want to come back? Let me know. And their masseters look like this. We might want to make a device that allows them to move a little bit more and might hold up to those massive forces that they're going to place on our acrylic in hopes that that it holds up.
And those are big masseters. You know, when we, you know, when we palpate masseters and we tell somebody, bite your teeth together hard, and I put my fingers right there on the masseter.
Yeah.
And I say, now relax. Now bite hard. You know, you get this like that. If they can't hold a contraction for more than a few seconds and that muscle starts getting real tired, you know, again, that's the using your brain part. So, you know, their teeth are worn, they have real big masseters, and they have a real big tongue. As we go through this and we start to now, you know, we're gonna make some sense out of which device we use more often in each one of these particular instances.
Yeah, as we get to those in a few minutes, but we want you to think about this because we can't just say use this one here, use that one there. We'd rather teach you the process by which we learned that, and that way going forward, you'll be a better sleep dentist. I think that's where we strive, where we succeed rather, as educators in dental sleep. We don't just throw a bunch of information at you. We give you information that you can continue to use, teach you how to think about this, not just, hey, use this device there, because that's not going to help the next time something's a little bit different. Hopefully you'll learn to think about it here. And I don't know, is this your dog, Rich? I don't know where we got this picture, but man, he's got a deep bite, doesn't he?
Yeah.
Does that matter? I think it does. A deep bite, you know, we mean when the upper and the lower incisal overlap is a lot, like 8-10 millimeters, where the lower teeth go way up into the palate. Does that affect which device we're going to select?
Yeah, and the reason that we talk about that is, you know, you have this kind of envelope of function with your jaw where you open, you move your jaw forward, you can actually close a little bit more and move your jaw as far forward as you can. But as you open, you can't move your jaw as far forward. And honestly, Guy, some of the devices require significantly more vertical opening than others. Yeah, so if we had somebody with a really deep bite and they didn't have a big range of motion, then we might not use a particular device because it requires more vertical.
Yeah, and we have to understand if they have an 8 millimeter vertical overlap, that they have opened up 8 millimeters before we've even put any acrylic in between their teeth. So
Right.
You've got to add that 8 millimeters to however thick that device is. That's a different way of saying maybe the same thing, but if we have a device that opens them up 10 millimeters, we've actually opened that patient up 18 millimeters. So we might want to think about a thinner device. I think that's the point there. And you know, this is something you and I think strongly agree on. And I have to say it's one of the bigger mistakes that I made. So listen up, everybody. If you're new to this, we've made a lot of the mistakes for you. So hopefully you'll learn from us. Not paying attention to the nose will probably bite you as much or more than anything when it comes to lack of success in dental sleep. I'll say it in a more positive light. The nose and whether they can breathe through their nose at night or not is extremely important to success of treating apnea, even with dental devices or CPAP as far as that goes. And there are things we can do to improve their airway, their nasal airway.
Or even snoring. You know what I say, Guy?
It's true.
I say the better you can breathe through your nose, the better our dental device will work.
Yep.
It's just that simple. Because
Yep.
if they can't breathe through their nose at all and then they complain, well, your dental device, I'm still snoring some. Well, you got to clear your nose up still. I mean, that's one of the first things I told you was the
Yep.
better you can breathe through your nose, the better our dental device is going to work.
Absolutely. So we check that. We ask them if they have allergies. Ask them, is this a normal day? Yeah, I breathe a normal day. Then we ask them to breathe through their nose, and I actually just take my finger and close one side of the nares and have them breathe through, and then have them breathe through the other side, and we assess whether we feel air is going through there adequately, and whether it's a typical day or not. And we will have discussions about referrals to allergists, ENTs. At least we put that on the table at the beginning, so we're not, like Rich said, making excuses later if things aren't going exactly the way we want. And we talk about if it is allergies. Here in Florida, allergies are really pretty prevalent, and things like topical steroids, nasal quartz, the one I like the most. I discuss with patients, nasal cones. There's a lot of things we can do, but again, that's maybe a little deeper into another subject. But at least talking about their nose, documenting whether they can breathe through their nose, and letting the patient know that the better you can breathe through your nose, the better off we're going to be. And if they're not breathing through their nose, letting them know, hey, this might be of concern. And if you're looking to build a dental sleep practice and get referrals from physicians, there's not a better way of getting referrals than to
give referrals.
yeah, to give referrals to an ENT. I just saw a question come through. Does everybody see the slides? Rich, you're seeing them fine. I don't think there's any issue. I think that's an isolated
Yeah, I'm seeing them fine. Guy, I wanna drive home one point there that you said. It's much better to talk about this on the front end than it is to make excuses for it on the back end. I mean, you know, we've done that a number of times, haven't we, Guy? That's why we have we have made all of these mistakes. So we're and you guys are getting a lot of information here tonight in just an hour. It's probably too much to even remember, you know, and that's, again, is why, you know, as you want to partner with somebody who's helping you do this, because you have 1,000 questions about how to do this, and that's what we try to do. So patient dexterity, that's probably one you got from Florida there, that picture, Guy.
That's your typical Florida patient there, yes, sir. And just go out on the street and grabbed one and brought them in and grabbed a picture of. No, I mean, we're I say that I just left my mother's 82-year-old. My mom's 82, and she was having a dinner party, and I was helping her, and this did pretty much look like everybody in the room, but you know, and just having them hold their plates was difficult. So you might want to think about your patient and can they put this thing in and out. If they need to adjust it, are they going to be able to adjust it? Are they going to need to come in every time for you? If it has rubber bands on it, are they going to pop off and not be able to put them back on? So, I mean, we're saying this kind of jokingly, and we certainly don't mean to offend anybody. Hopefully that's not the case. But we do need to think about this, because everybody can't manipulate these devices as well as others. And ask me how we know that, because I've made that mistake, and the patient can't get the device in and out of their mouth, and we end up thinking, oh, geez, we should have made them another one. And cost. Yeah, you can pay $305 for the ClearDream, or you can pay twice that or more for other devices. You know, I think it's a factor sometimes as we get more systemized with this and doing things more efficiently. But in my office, we charge the same amount no matter what device we do typically. But you do have to be aware that they can run anywhere from a few $100s to $600 or $700. I think the average, I would give it at $350 to $400 on the devices. Anything more you want to add on that, Rich?
No, that's good.
All right, there's our device selector again, and I'll use this opportunity. I know some of you signed on a little late. We're answering the questions as they come. We'll stay on afterwards. We're about halfway through. If anybody wants to come to one of the courses we're doing, we'll put those up again at the end. You just type in course if you're just interested. That'll just secure that Jody or Brandy will get a hold of you and give you a nice discount on our courses. And if you want to speak to Jody or Brandy or one of our member support experts to talk about your practice and how we can help, and how the DS3 system will help you do that, then just type in demo, and we'll call you up and show you how our system works, and we'll actually give you a lot of valuable information as well. So just type demo at any point, and again, we'll put that up at the end. We're going to get into the 4 devices in just a moment, but first I want to talk about the 3 materials that the inner surface of these devices are typically made of. So the 4 devices we're going to talk about, but the part that touches the teeth can be made out of, at least the four we're going to talk about, three primarily different materials. And I'll talk about the first one, Rich, if you want, and you can add anything. The first one's acrylic. I'll talk about it because it's easy. You all know what acrylic is. So the device is acrylic, and it's acrylic through and through. And the advantage to this is that you're familiar with it. You as dentists work with acrylic. You're used to adjusting acrylic. You've got burrs already. You know how to adjust on these things. You can get it with these little ball clasps that you can see on the bottom one here, or without them. Those ball clasps you can adjust to make tighter. If you get them with those ball clasps, make darn sure the lab covers the back tooth, the distal of it, so that you don't have an orthodontic device that causes those teeth to spread apart. Some of the labs won't cover that distal of the back tooth, but with the ball clasps, you can adjust it. You can reline this. You can often make these devices thinner, especially the ClearDream, because the ClearDream has been, again, is that injected molded acrylic, and it can be made very, very thin and still be extremely strong. So that's what I like about acrylic. Anything that I missed on it, Rich, that you want to add?
The other thing I would say, Guy, it's real easy to grind off. I mean, I think we learn as dentists, when you get into thermacryl and some of the other stuff, it gunks up with your burr and stuff like that. So this is just simple, I think the main disadvantage, because I've worn all these devices myself, is it's a little less comfortable, to have that hard surface. But the bottom line is people get used to anything.
And I think it is when you initially put it in, but I think if you don't know the difference,
if you don't know the difference, you don't know.
You don't know the difference. But for the comfort, then this is the one you would choose, Rich, for the comfort, I assume, the flex material.
Yeah, it's the little soft, spongy stuff. Some people call it flex, dual laminate. It's just a little, I don't know, what is it, Guy, 0.5 millimeter, 1 millimeter or something that goes on the inside of, again, this is the part that's touching your teeth. So it's a little more forgiving. The device doesn't have to be as exact fitting, but the plus side to this is it is more comfortable, right? You do have to make it just a little tiny bit thicker to do that. It can delaminate from the underlying surface. All of the manufacturers say, hey, don't use any alcohol containing rinses or anything on these things. And this is a little bit like, the weak spot in anything is where two pieces come together. If you're going to splice a wire, where does it go bad? Right where you connect them. And those two pieces that come together like that. So this is another good reason to get people in to do the checks, because sometimes if it starts to delaminate, we just take a scalpel, Guy, and we go in there and we cut part of that off down to where it's a clean surface again. And then it won't, once it starts to delaminate, then you get saliva underneath it, and then the whole thing can be a problem. And it can discolor a little bit. But, overall, all of the materials that we're talking about can use. And if a patient doesn't know the difference, then they don't know the difference.
Yeah, and I think so. The bottom line on this one is comfort. I would select it, and then flexible around the undercuts too. If they have real diverging teeth, and it's going to be hard to get retention, it'll squish around and get into those undercuts for these teeth too. And so it came in. Which one do I prefer? It depends on the patient. If I'm more concerned about comfort than this, if they have the diverging teeth rather, I'm thinking flex material. If I want ease and comfort, I personally wear a hard acrylic one myself. That's what I've been used to, and I think it's it lasts longer, and I'm just don't see a problem with it. And then Rich, I'll ask you to talk about thermacryl after I give the introduction. That Rich has been on me to use thermacryl years ago, and I'm like, oh gosh, I got this material and I have to refit it, and it's kind of ugly, and we even have a video that I was going to play, but I'm afraid you wouldn't hear the audio. So finally, Rich got me to drink the Kool-Aid and do the thermacryls, well, probably 7-8 years ago now. And I think part of it is the labs come a long way with how they use it. But man, I'm addicted to thermacryl, Rich. So you want to talk about your favorite material on earth?
Yeah, this is holding the transducer on my trolling motor on my back. It's got a lot of uses, but the thing about this, Guy, is it always fits.
Yeah,
if you that guy, your assistant takes 3 impressions on, and you yell at her because you wasted 400 $1,000 of PVS, and then you go in there and you do 2 and you still can't get it, you know, use Thermacryl, you know, because it always fits. Maybe they're going to get some dental work done, you know, they need a couple of crowns here and over here or something like that. So this is something that when you heat it up, you get about 150 degrees. It gets soft and clear and gooey. It's kind of like sticky Play-Doh then. And then you just mold it to the teeth. So you push it down, and then the longer you hold it down, the more retentive it becomes. And please don't take a phone call or something like that when you do this, because I've only had to cut one out, guy. Just one. That's all it takes to cut out where you think, man, I'll never do that again. But it's usually heated up till it gets kind of clear. And when these things come back from the lab, that's what they'll look like. That layer of Thermacryl is bonded to the acrylic of the device, or the BioCryl, or whatever the outside shell is. Mm-hmm. Then you put it in a hot water bath, 160 degrees. Then you seat it in the mouth. We count to about 10, and then we tease it halfway off the teeth. And then we push it back down, and we count to 20, and we tease it 3/4 of the way. We push it back in, we count to 30, we tease it all the way off. That's our 10, 20, 30 rule that we use, and it works really well most of the time. The downside, guy, these things do pick up a lot of stain and odor. You know, we always joke at the office that we can tell the vegetarians from the meat eaters, because the vegetarians are green and the meat eaters are brown, you know, when they come back, if they're not flossing their teeth. But overall, it's a good material. Just like Guy said, all of these are good. It is a little harder to adjust. You have to use a real sharp scalpel. You can't grind on it with a burr, which is probably the biggest downside to dentists liking this, don't you think, Guy? They can't grind.
And it's stain. The only thing I'll mention, it does kind of stain over time. And so tell your patients, hey, look, this might turn a little stained, a little yellow, a little green over time. And most patients say, what do I care? It's in my mouth. But there's a few patients who do. And you want to make sure you mention it to them. If they're real neurotic, then you don't want to use this. But other than that, it always fits. And I'll tell you the other thing I use it, Rich, is someone's going out of town and I've got to get this in, and we're rushing the case, and they're going to Europe for a month. I know it's going to fit. You know, I know that there's no way it's 100% it's going to fit. And so I like it, and I keep it on my boat now just in case I got to repair something. And you know what? I've never got one stuck in the mouth, because after you told me that story in detail, I learned from your mistake on that one, at least so far. So, yeah, don't be afraid of the materials, the bottom line. I mean, I took a long time to start using it, and now your team can do this material for you. And it really doesn't even increase if you take the overall seat time, because it's always going to fit. I think it's overall less time. So, and again, it's not for everybody. It's not for all devices too. So we gotta decide which material to use where. All right, we're going to talk about the 4 devices now, believe it or not. But hopefully the rest of that was important, because it's going to make you think about these devices as we describe them. So the dorsal is I would say, is my favorite overall device. For me personally, I wear that one most nights myself, and I think I'm just going to go to the next picture. Now I'm going to go back on this one. Sorry. Let's just describe how it works, Rich. You want to tell them, or do you want me to? Go ahead and describe how that mechanism works pretty quickly.
The upper screw is just a jack screw, just like they use in palatal expanders or anything. Yeah, right there. And you just put a little keyway in there, and you turn that. One side goes down, the other side goes up. And that pushes the forward part of that, just that part right there that Guy's pointing at. That pushes it forward, and that pushes against the fin, which moves your jaw forward. But like Guy said, these are the most comfortable devices out there. I've worn them all. Guy's worn, several different ones. And, they are advanced in very small increments. It takes about 10 clicks of that thing to advance at a millimeter. So we're usually advancing somebody, Guy, about a 0.5 millimeter a week, That's kind of our standard, 5 clicks a week is if you're still snoring, as long as you can tolerate it and you're not having any trouble. But it does allow your mouth to open. And we talked about retention, Guy. Remember you said somebody, yes. And this is a case where, if somebody didn't have, they had really straight, really small teeth, this would be a great device for that person because it doesn't have to be stay in as tight. You know, when we get to the Dream Tap, those have to stay in because they're hooked together. Yeah, so this might be an instance where you might use that a little more.
Yeah, so anytime your mouth can open with the device, it doesn't have to fit as tight, just like Rich said. So this is one of the two devices that allows opening. And because it allows opening, it's more comfortable. Patients can swallow, but then there's always a but. If you can open your mouth, we lose some control over the airway. Because now when you open, it can negatively, it can sometimes positively affect, but eventually if you open wide enough, it almost always negatively affects the airway. So anytime you have a device that allows your mouth to open, put some sort of a mechanism to be able to put rubber bands, orthodontic elastics between the two arches, because now we can control how wide you can open. Because if you open too wide, again, we lose a little bit of the predictability of the dental device. So the people we use these on are people who cannot breathe through their nose well, like myself. That's why I say I like it for me, because you know I can breathe through my mouth. If I can't breathe through my nose and you lock my mouth together, I'm more claustrophobic. I feel like I might choke because I just feel like if I want to open up my mouth, it makes me nervous. Not to say I can't wear a tap, which we're going to show you in a moment. I can, but I'm more comfortable in a dorsal design. Retention issues, deep bites like we talked about, you know, when you have that vertical overlap, well, we can make these much thinner. And again, it's the most comfortable one. The people I wouldn't do this on are the real heavy Bruxers, maybe class 2 and 3. There's some negatives to that, but I wouldn't put too much emphasis into that. But severe disease, because of that ability to open, I'm sometimes more inclined to do one of the two devices that keeps your mouth more at a fixed vertical position. And I'm not saying, I've had dorsal designs that have taken apnea that's way beyond severe and made it better. But overall, the ones that hold your jaw together at a more fixed position, I think are a little more predictable. Anything else on the more
The
or
only
less?
thing I want to add, Guy, I know some of you guys can't see the slides. I'm sorry about that, but I think 99% of us can see the slides. And what we're going to do with all these devices, you know, this is the more or less. There isn't any real hard lines here, are there, Guy? There are very few real hard lines. Most of these things are like, we would use this more in a patient who had a big tongue and couldn't breathe through their nose as well, you know, who had retention issues. But that doesn't mean that with somebody that has a big tongue and maybe they can't breathe through their nose that you wouldn't make them another one. But if you're taking notes and you're looking at this stuff, this is the take-home stuff where it's a little more, I would use this device, and if a little less if I had these things. But what are you seeing here, Guy? Aren't these all of the things that we talked about in our exam?
Absolutely.
As we're looking at that? Yeah.
Absolutely. And that's why that exam's important, so that you can walk yourself through this. And again, at the end of this, I'm going to tell a patient, hey, you know, I've done your exam. I've done this before. And if you haven't done it before, I learned this saying from Rich: fake it till you make it. Act like you've done it before and say, through my vast knowledge, I think this device is likely the best one for you, but I want you to look at it. And it really helps to have a model to show them as well. So, all right, let's talk about the two Medicare devices that we do. Medicare, if you become a Medicare provider, the devices have to have a further approval beyond the FDA clearance, and that is that they have to be approved for Medicare. And there's really only two devices that Rich and I recommend for those. And the good news is they're about as diverging of devices as they come, aren't they, Rich? I mean, the pros and cons are on kind of opposite sides of the slide that we're going to show you in a minute. So it's good that we have two devices that are a little bit, not a little bit, they're quite a bit different. Dream Tap we'll talk about first. The tap went a little too far. You know, the taps have been around for a long time. How long have you known Keith Thornton, who invented this, Rich?
Oh, 20 years ago. You know, I started with the Tap 1 with the little screw on the outside. Then they went to the Tap 2. Then they went to the Tap T. Then they went to the Tap 3. Then they went to the Tap 3 Elite. And now we're on the Dream Tap. So, yeah, they've been around for a long time. And I think for the most part, we're making improvements. You know, the hardest part for us, Guy, was going to the Dream Tap, was everything's upside down and backwards now.
Yeah.
You know, we always had the plate on the top before, and now it's on the bottom. So instead of turning to the right to go forward, now you got to turn to the left, etc. So, but you know, there's about 6 millimeters range of motion in each one of those hooks, and they actually come with 3 hooks now, and you can get these on the inside. You can get the flex material, I believe they call it the dual laminate, and then you can get the thermocryl as well with these when you're looking at the inside.
And while you're talking about that, I recommend the thermocryl on these most of the time, because the difference here with this device, now you can envision this thing hooked together. This hook's going to go around the top one. It has to fit fairly tight because it's locking the jaw together. Back to now, we don't have to worry about the vertical. It's locking the jaw together. But if it doesn't fit tightly, the patient yawns in the middle of the night, opens their mouth, and it's going to pop loose. It's going to unadhere to one of the arches, usually the lower, and they'll wake up with this thing hanging on the top arch or something like that, and they'll have to get their jaw repositioned and bite back down into it. With the thermocryl, you have the ability to go ahead and make it fit tighter. So you know, I think Rich has already gone over these pros and cons. The more or less, I think, is the real important thing here. Rich and I have had this discussion. We've been using taps for years now. The Dream Tap's a big improvement because it has a big improvement because the hook's been moved to the bottom, and it gives more tongue space. But I think the biggest advantage of this one is it just works. If I had to say the one device, you know, gosh, this guy really needs this to work. He's got severe apnea, and I want to give him the best shot of this thing working. I'm going to pull the tap out of my bag of tricks as long as there's no contraindications to it. Do you still agree with that?
Yeah, and that's not just my opinion and Guy's opinion. I mean, when you look at the 2015 practice parameters and you look at every one of the devices and you actually look at which ones did better for severe disease, the tap kind of seemed to float to the top. Now, we're not, you can take somebody who has severe disease and put them in a dorsal, and it may treat their apnea well. We're not saying that the other ones don't work, but this is just day in, day out. If we take all comers, you know, we look at this, and I think, Guy, that there's something different about pushing or pulling from the side as to kind of hanging your jaw off the front, you know. In some way, it kind of lets your jaw relax in some ways, but
yeah.
I don't know.
And this is also good for Bruxers because it allows lateral movement, but it almost acts like a built-in NTI. But the people it's not good for, Rich, is people like me who can't breathe through their nose and you're claustrophobic, or if you want to open your mouth, it's less comfortable. So if I have someone who's severe apnea and they're claustrophobic, can't breathe through their nose, I'm not making this device on it. I'm going to make them the dorsal, or maybe if it's Medicare, I'm going to make them the next one that's a Herbst. So I think we probably ought to move on. I'm looking at the time there, so we'll get to the Herbst. But the bottom line on the tap: severe apnea, Bruxers, fantastic. It's great for decreasing muscle activity, but it's not quite as comfortable as this device here, which we call the Herbst. I'll describe the Herbst while I'm talking. The Herbst basically has 2 arms, and they comes in a single and double barrel. So some of them actually have 2 of these little screws here. And as you turn this screw where my arrow is towards this plus sign that you can't see very well, it'll move that piston backwards and move the jaw forward. Now, they've gotten smart with these, with some of the new ones. I don't know if I've got one with the dots on them, but these are some older slides. I probably should have updated them. But the ones with the newer, most labs now will put a little dot right here so that you can see that that's the direction we go. And I think you're going to see some of the pros and cons are very similar to the dorsal because it allows opening, with the additional advantage of it being a little more sturdy and allowing more lateral movement for Bruxers. So if someone's a Bruxer and wants opening, I'm more inclined to do this one, but this one's a little scarier and a little more cheek irritation, so as compared to the dorsal. Some patients look at this and if they're real apprehensive, you might want to talk about it. And notice these little ball clasps here. Those are for those elastics, because again, this patient can open with this. Well, that may be great for comfort, but it can also cause patients to have less predictability. I've had where the elastics went from this device not working at all. I mean, both symptoms and follow-up. sleep test to where it's working fantastic. So, Rich, you want to more or less on this, and we'll move on to the EMA?
Yeah, this is very similar, that guy said, to the dorsal. So the bigger tongues, and I can't breathe through my nose as well. I think that some of the takeaways from this are stay away from the tap. So you got big tongue, you can't breathe through your nose.
Right.
Then I want to move the adjustment to the side. So
Right.
the dorsal or the Herbst. So these are very similar to the dorsal. You know, again, we see less for poor dexterity. You know, if somebody can't get that little keyway into that thing to turn it. I mean, we have a few patients, Guy, that they just come, you know, they live.
You have to come in to adjust it.
Yeah, they just come in and we do it. So it's not a deal breaker by any
Right.
means.
Yeah,
but
there's two things with the dexterity. If you want the patient to adjust this at home, can they do it? And then can they manually take the device in and out? For patients, if you don't mind adjusting this one yourself, then poor dexterity is not an issue, is what you're saying. They're going to have to come in for each adjustment, though, as opposed to the way we're going to talk about it here in just a second with them at home. This is the one you don't want to do on patients who have poor dexterity. And the reason being, if the EMA, it's these little elastic bands, which works great, but those are going to come off while the patient cleans this device. And if they've had a stroke and only have the use of one arm, or just aren't very, you know, or just feeble, can't see well, or some have glaucoma or something, they're going to have a hard time getting these bands back on there. And you don't want them coming in your office every morning for you to put these things, you know, back on so they can wear it again, you know, that night. So the EMA is a device, the fourth one. And how far is this apart here, Rich? This is the normal.
That's a normal class 1. You know, those buttons, if you know, with the picture of the EMA guy showed, the maxillary button almost always goes on the canine, and the lower almost always goes on the first molar. So if you take somebody who's a normal class 1, they don't have premolar extraction for ortho, something like that, that's approximately 26 millimeters. So, you know, if we put them in a 22 millimeter band, then they're protruded about 4 millimeters. So that's about where we start for class 1. But you know, again, the other part I'll mention for dexterity with this too, Guy, there's not quite as much to get a hold of, you know, to take these things out. They're a little bit easier to get in because you can kind of line them up and push on them. But you know, those little buttons there, those aren't handles to take them out.
No.
So that's what people think they are, you know. So those things will pop off a lot of times, and if they come off clean, you just kind of roughen it up, your salt and pepper acrylic, you know, put it back on, put it in your pressure pot. You can do that. But these, you know, I like these things because they're small. They're the lab fee is the least of any device. This is the least, and they do last pretty well. I had a patient come in the other day, Guy. She swears she worn this thing every single night for 10 years.
Wow. Yeah,
and
that can certainly last.
Yeah, it was amazing, you know. The cons, maybe they're not quite as durable in some patients if they're real heavy bruxers or something like that. So, you know, that's the less on this. So again, everything that we talk about is a little more or less. And I think as a dentist, you know most of this intuitively already. You know, if you had the patient's models and then you put them together and you took them apart and you had your little notes from DS3 about how far they can move their jaw, and then you looked at each one of the devices and you go, oh, I think an EMA would work good. And then you looked at their model and they didn't have any molars on the lower right. You go, oh, geez, well, that doesn't make sense, you know. So again, big tongues, can't breathe through their nose as well. I say not so crooked teeth because you know, I don't have a surveyor in my office, Guy, but some dentists probably do, where you go around and you know, you're going to look at how much undercut each tooth has. And on really crooked teeth, the problem with this is there's nothing left of the device, you know, because you have to keep it above a height of contour at some point.
Yeah, absolutely. And it's one of the most aesthetic ones too. I mean, some patients care what these look like. And so they'll say, hey, this, you know, if they seem real picky, they're worried about how their significant other, or if they're single, whatever they're thinking, that's a good one too for them. And it works really well. I mean, I've had this device take severe apnea and make it make it almost non-existent. It's one of the smallest devices out there too. So if someone's got a concern about having something in their mouth, it's one of the smallest ones. So when you get up in the mornings, we need to talk to our patients about getting their jaw to go back. And we're not going to spend a lot of time on this because we're getting close to the end, but suffice it to say, if they get their chin and jaw to go back in a normal bite every morning, the chances of bite changes are significantly reduced. My and Rich's favorite way of doing it is something called an AM aligner. If you talk to one of our member support team, if you call up and type in demo and get Jody or Brandy, they can show you some videos on how to use these AM aligners and remake them. And basically it makes a jig, as I would call it, because I used to do a lot of woodworking and working on cars and things, so it's probably not a dental term, but it's a repositioning existing CO bite that you get them to go back into every day. And if you do that, you're going to decrease the chances of having bite changes. So get them using the repositioner, we get them wearing their device, and now they're going to come back. What do we do from here? And we may run 5 minutes over, but I think it's worth us going through this for you all to understand that there's really 2 goals of treatment, but I call it 3 because the first goal is for them just to wear the device. And I discuss this with 100% of my patients before we ever send them out the door with their device. Look, this is a 3-step process. We really have 3 goals here. One is you got to wear this device every night. If you're not wearing it for some reason or you can't wear it, it's uncomfortable, we need to figure out why not. Once you wear it, we want your symptoms to improve. And if they're unimproved, we're going to move the device more forward. And then ultimately, if you have apnea, we want to make sure that it's getting your apnea to an acceptable level. So that's our 3 goals. And you know what? I think the reason dental devices many times work better than CPAP is we do it in this order. CPAP, Rich, it just occurred to me the other day, you may not even heard me say this, CPAP does this backwards. They test you with the CPAP. Yep, it worked. Your AHI is 3. Okay, I hope you feel better and I hope you wear it. You know, we start with the wearing, and I think that makes a difference. And when we start with improving their symptoms, then they're more inclined to keep wearing it, because that is, you know, who wants to live forever if you feel like garbage? Part of this is feeling better, and part of it is objective success. So, you know, if they're not wearing the device, let's find out why not. And, you know, you all are dentists. We can help you on this, but most of you can figure this out. It's hurting this tooth, hurting that tooth. It's too tight here. Let's adjust it and so forth. And that's usually not the problems we get. The problems we get are, yeah, I'm wearing it. Is it working? No, I'm not feeling better. How do I know? What does no mean? And that's where having a system to look at these subjective symptoms and decide whether you need to adjust it more. And after you adjust it more, you need a system to look and say, is it working again subjectively? And ultimately, if it is, then we're going to do a follow-up sleep test on our patient. So our system for doing this, when our patients come in for a new patient exam, we ask them the same targeted sleep questions. And this may not make sense to some of you who aren't that involved in sleep, so I won't spend a ton of time explaining it. But these numbers and these abbreviations stand for things like Epworth Sleepiness Score, which is how sleepy someone is, snoring levels, energy levels, sleep quality. And what we do is the patients put these in through our web portal. We know what their symptoms are. We know their chief complaint. We get them the device, check mark, they're wearing it. Now they come in and we enter in their new symptoms. And very rapidly we can see at a glance through our DS3 system that this patient went from a sleepy person, which is an Epworth of 19, to 8, which below 10 is not sleepy. And snoring levels have gone down. Energy levels have gone from a 3 up to an 8. And very rapidly we can see that they've improved. If for some reason they hadn't improved to where we want, then as Rich mentioned, we're gonna typically adjust our devices. What do you usually do, Rich? About a 0.5 millimeter per week? That's what I usually do.
Yeah, and we like thirds. You know, I like the third rule for some reason. And you're gonna be a little more aggressive in the first third and a little less aggressive in the middle third and much less aggressive in the last third. And we tell patients that. We say, look, you can move 10 millimeters. We're starting you at 3. You can move the first one, you know, a little bit quicker, and then we're going to slow down. This is a marathon. It's not a sprint. We tell people it's a marathon, and this is the first thing. I love your goals, guy. I'm going to make a big old poster of that and put it in my delivery room. You know,
Right.
You gotta wear it. Then we want you to feel better and snore less. You know, and we always talk about chief complaints and what we're doing, and then we're going to go back and test you. You know, I saw a couple questions in there earlier, guy, about, you know, do we really need follow-up sleep tests? Well, if somebody comes in, they got an AHI of 100, apnea, hypopnea index. They desaturate to 52%. The guy, I mean, there's a risk he's going to die every single night that he goes to sleep. Yes, you have to do a follow-up sleep test with that guy. Now, that's different than somebody has an AHI of 5. You know, so again, you got to use your brain. But as a general rule, get them sleep tested, but you got to have a system and you got to ask the questions, and that's what Guy's been going through.
Yeah, and sometimes it's not as simple as I put on the last slide. Sometimes they're a little bit better, and then we adjust the devices for a few more weeks, or the patient usually self-adjusts them, and then they come back in, or we call them on the phone, or they visit our web portal, and we put in new symptoms again, and we determine once we've reached their subjective success. And you know what? Most of the time, if we talk to our patients at the consultation, we identify our goals of treatment, and you have a system like we have through the DS3 experience that to look at symptoms ahead of time and re-identify them the same way, we usually reach subjective success the majority of the time. That's not any BS. We really do. Most patients, we set a reasonable goal and we achieve it. If it's snoring, if it's sleepiness, if it's not getting up and going to the bathroom as many times a night, typically we reach those success. So after that, we're going to want to do a follow-up sleep test. And there, you can do it in the sleep lab, but what we prefer to do is do a home sleep test if the patient's doctors and everybody's in agreement. That's a whole nother subject for another day. But if we're going to do a home sleep test, we used to do one night, and then, oh, well, it's not quite where we want. And then we do another night. Well, let's move them a little bit more. So now what our protocols are, we again have their information, their sleeping, the scores here, which are, that's the number of apneas they're having an hour, which is about every 2 minutes, this person, 30 an hour roughly. We test them in 3 forward positions where their symptoms were acceptable, and then 2 more forward positions. Or sometimes we can just split the difference and do 1 more forward. But look how quickly, if we have a system for this, that we can see, wow, they went from 30 events an hour to 19 to 8 to 6, and their oxygen levels are improving. And so having a way to follow up sleep tests is important, and we have a system for doing this that makes it far, far quicker and easier than what we used to do, 1 test at a time. And then ultimately you need to write some letters to their physicians letting them know what your results were, and our DS3 experience system makes these letter writing to where it's a click of a button and it pulls this data and faxes it like magic through the cloud. So you can do it at the sleep center too, but that's a lot more convoluted and probably a subject for a different day. So you know, hopefully that was helpful for everyone. I do want to mention that I'm trying to, I'm sorry to keep rambling here, Rich, but I'm trying to get us back on time here because we try to respect everyone's evenings, is dental sleep therapy is really just steps. And I made this slide about a year ago, and I wanted to make it look like steps because that's what it is. You just have to have a system and accountability and someone to do that system in your practice for each of these steps, from screening to testing to taking doing consults, impressions, delivery, follow-up testing, and then we see our patients 6 months and then each year thereafter. And with our DS3 system, you can do this easily with only 45 minutes of dentist time. It takes me roughly 30 minutes or less with my patients because I've been doing this a long time and we have a very efficient system. There's no reason it should take hours and hours of doctor time to do this. What do you, Rich, you fall within a 30-minute category on that?
I'm getting more like you in some ways, guy. I just go, hey, Ashley, adjust that guy's device, or, you know, so if you surround yourself with really good people, and here's the big part of this, you front load their training.
Yeah.
You know, it takes a little bit longer in the beginning, but now you've got really good people you've surrounded yourself with, and your staff and your people can do all of that stuff. Then it takes a whole lot less of your time. And you know, you guys have learned an awful lot tonight about, you know, how to really evaluate a patient, and then how to use one of 4 different devices, because in some patients a device will be a little bit better. And you mentioned this before, Guy. The last thing I want to drive home is you have to have samples of these devices. You could get by with pictures, you know, but if you have all of these devices, and I put all of these 10 things, Guy, that we talked about evaluating people, I call it my cheat sheet. And right there in the consultation, I say, well, let me evaluate these things, because this is how I choose which device will work best for you. And then I just tell them, this is the one. I don't give them an option. They go, well, I like that one because it's pink. I said, well, you know, get some pink spray paint or something and paint this one pink or something, because this is the best one for you. Don't leave room for guesswork there. You know, be affirmative and be confident in your decision.
Well, and that's what we put together with the DS3 experience. You know, those 10 checkpoints are built into the DS3 system and to our software, but that's not all we have. DS3 experience provides education, coaching, software support, and all the needed instruments for success to implement the 4 pillars of dental sleep medicine, which are screening, testing, treating, and billing. So you can read that for yourself. That's what we do with DS3. And if you are still listening, we're going to stay on to answer all your questions, but I want to emphasize that we can help you do this in your practices. We can help you do this through our courses that we do. We offer them. I think I've got a slide coming up here. I'll come back to that one in a minute. There's the slide with the courses. And if you type in course, Jody or Brandy will get a hold of you, and they'll give you a discount on one of the courses. If you know which one you want to go to, you can put that in, but that's not absolutely necessary. And type that in to secure your discount. We teach them all over the country. We have a lot more time, so we can get through this in much more detail on how we do this. Also, I want to mention that you're going to get a survey at the end of the night tonight when this is over, and it's basically to help you identify what you need in your practices if you want to do dental sleep. So go through that survey, look at the questions, and see where you are in your dental sleep medicine practice. And you'll have an option at the end of that to ask to talk to one of our team. Jody or Brandy will be the one likely contacting you, and they can answer your questions that you had about the survey, see how you did, answer if you have specific implementation questions. We're happy to answer some of those for you, because that's what we do. That's why we exist at DS3. And as well, if you want to learn about our system, see some of our videos, tap into more of our education, and see what we have to offer there, and then just type in demo, and one of our team, Brandy or Jody, will contact you. And it'll only take about 30 minutes of your time to see what we can do and how we can change your lives as far as how you treat your patients and how you implement dental sleep in your practice. So that being said, what else, Rich, you have?
No, because it's a process. You guys have to remember, this is a process. You know, you don't listen to a webinar for an hour and you're like an expert now. So you know a whole lot more about which device to use in which situation now than most dentists do, because most dentists don't know this stuff. And Guy and I know this because of trial and error. You know, we didn't have anybody to call in the early days. You know, now we're here to help you guys do this. So I see a lot of people typing course and demo. And anyway, thank you guys so much for spending the evening with you. We'll hang out and answer a few more questions if we need to, Guy. But
yeah, and someone asked well, first of all, by the way, subscribe to our magazine. I have that on there. That's free, no obligation. Comes once every other month to your inbox. And we have some great videos, articles that can help you. So you can go to dentalsleepinsider.com to sign up for that. If what someone was asking what we do at the courses, we have 1- and 2-day courses, and we call it the 4 pillars course. And I'll go back to that slide so someone wants to see more on that, I think. the 4 pillars courses, because we go through how you screen your patients in your office, how you test them, what systems do you need, how do you train your staff, and these courses are great for staff as well. How you treat, so we get into a lot more detail about these devices than we can in an hour's time. And then really probably most importantly, how do you bill? Through medical insurance, how is that done? So if you want to learn that, our course is the one to come to. If you want to learn, why apnea causes diabetes, probably not the course for you to come to. So there's a lot of courses out there that can teach you. But if you want to know how to implement this in your practice, then come to our course. The one-day courses give you all the information you need to do it. You can go back and get started in your practice immediately. The 2-day courses add an element of more hands-on. We get to deliver some devices. We get to spend a little more time taking bites and doing some of that sort of thing. So that's what's really fun about the 2-day course. We get to have a little more time, but you get all the information either way, and the courses are extremely reasonable. And again, if you type in course, then Brandy or Jody will get a hold of you. You don't have any obligation, but at least you'll secure your discount. So that's, I think, hopefully answers that question. Anything other technically, Rich? Did anybody have hands up that didn't type in?
I was just doing one. Somebody had a question about the EMA. How do you decide which strap? Well, remember, are they class 1, class 2, class 3? So what I do is I put the upper and lower in, and I have them just bite their teeth together, normal. And I just take a little millimeter ruler and I hold it in there and I measure the center to the center of the buttons. And if it's 26, then and they can move 10, then we start them at about 3 or 4. So that would be a 22, 23, band, something like that.
Right. Yeah, I think that's the difference with the EMA is you don't know. It depends on where they put those buttons. So that's why you've got to kind of do that, in their mouth.
Yeah, and Dr. Guru said something about, he's screening his patients and sending them to get a sleep study, and they never come back. So
never heard that, Rich. That's a new one on me.
Gosh,
that's why
I've been doing it 17 years now, and I just go tell the docs, look, if you're not gonna send them back, I'm not sending them to you anymore.
Yeah, Rich and I started this business. I mean, and I say this sincerely, that we started it because we were frustrated, and we started it to try to make a difference. And I know that may sound cliche-ish, but it's the God's honest truth. And we were frustrated. And that question right there, Dr. Guros, is exactly why we started our business, because we were frustrated. We would send our patients to physicians and they would never come back. And then once we learned how to accomplish that in our practices, we tried to teach other dentists, and it just didn't work. And so we made a decision that we're going to find a better way to do this. And we have answers to that. There are ways to get your patients tested. And one is to have a frank conversation with the physician. That works if you're willing to do that. But what we learned, because we've been teaching dentists to do this for a long time, is a lot of you won't do that. You won't just go to that physician and say, listen, you're going to send me these patients back. Hey, doc, here's how it's going to be. We just know that's not going to happen. And that's what we teach you in our 4 pillars courses, are how each one of those systems, if you're not screening your patients properly, here's a quick and easy way to do it. If you're not getting your patients tested, that pillar's, you got a problem. Your castle's falling down, your dental sleep medicine practice isn't succeeding. We have a solution for that. Testing, treating, we went through some of that today with the devices, but there's a lot more to treating than we can go through, obviously, in an hour, and billing. So we can help you with that. It is a huge obstacle. We are daily coming up with better solutions, and many of those can be done with clicks of buttons through our DS3 system. So I think it's a fantastic question.
Yeah, and it's a fair frustration, and that's what we try to especially in the 2-day course, to try to get, there's more to it. There's more verbiage. We use a lot of, hey, this is what I would say in this particular instance, or something like that. And if you just, you're screening patients and you're sending them to them, sit down with a guy, have a cup of coffee, go out to lunch with him one day and say, look, right, man, the research is that these dental devices work. I mean, I sure want to crack at these patients, if they're mild to moderate, why don't you send them back? And if they don't work, then we can put them in CPAP, because he's going to get another sleep study out of it, especially if he owns a part of the sleep lab.
Ellis, I will answer your question in a second. Matt, the answer is you should absolutely bring your teams to the courses if you can. We make that extremely reasonable for the team, And if you do this the way we recommend, the team can do most of this. Your dental sleep patients can kind of run in the background of a busy dental office. I ran a very successful prosthetic dental practice. I mean, I'm not saying it to brag. I mean, I think it was, successful, at least by my accounts. And in the background was running my dental sleep medicine practice for years because my team did it. So yes, we highly recommend that your team come. If they can't all come, we have ways to train them through our system, through GoToMeetings and through our online treatment through the DS3 experience. But if they can come, ideally have them come. Have we used the narvals, the question up there? Yes, we have. It's one of the other devices we use in the 1% of the patients. It holds up extremely well to Bruxers. It has most of the same advantages as a Herbst without being as ugly with the arms, and it's extremely, extremely durable. The negative to it is that it's very hard to adjust. If a patient gets any dental work whatsoever, you can't really add acrylic to it because it's not acrylic, and the cost is on the high side. It's in the $600 range. So, but it's a very good device when used in the proper situation. One bit of advice on the narval: if you're going to do it, make sure they have 3 designs. Make sure you get the one that wrap at least some portion of all the incisor edges of the teeth to prevent tooth movement. So that's a great question. So you can check that one off as far as answering it. What else is on here?
The demo devices, I would make a couple for yourself, and wear them a couple of nights.
Yeah.
I don't know very many dentists who don't snore. The labs, if you say, hey, I really want to get into this, I'm doing it, can I get a discount? But a lot of the labs will do that. They'll extend that to you, so. And Medicare, you think about Medicare, guys in Florida, half the year, most of his patient population is 65 older. So he has to do it. If you live in a community where there isn't a single person over 65, then you don't need to worry about Medicare. So you have to evaluate that in your area. I think that as dentists, we should do that. Someday I hope to be 65 and I want to have a choice as to which doctor I see. So there are ways to do that, and there are ways to bill for that, where you can balance bill. And again, that's a lot of what you learn in the courses, a lot of the nitty gritty, about how to do this. And there is a better way to do it where you still can make it profitable.
Yeah, and I'd like to mention along that line is we have dentists in all states, and we have very successful dentists in all states. And we have dentists that don't get to the level that they want, but it's not because of where they live. I mean, this is all Rich and I do for a living, is help you all do this and then run our own dental sleep practices. It's not a demographic thing. The number of patients who need your help is through the roof. 1 in 5 adults has apnea. So one of the questions here, I have these physicians that are protective. There are ways to be successful in all areas. It does take some time with the doctor up front, like Rich said, front loaded, and you got to have someone on your team. I mean, if you got to have a good team member if you don't want to personally do this, which we recommend, and we can help you do that. If you're willing to put in a few hours of time, our dental sleep DS3 experience is 4 modules, roughly 2 hours each. Some of them are a little shorter than that, but we'll call it 2 hours on the high side, 8 hours of time to walk through. We have ways of making that very, very reasonable for you and your team to do. At the end of that, you have the tools necessary to go forward and start seeing patients, and you will if you want to do that, and most of our practices do. And it's not, the ones that don't are because they got busy golfing or something else, maybe, not because they live in a certain geographic area, because there's successful dental sleep practices or offices that have in their practices throughout the country. All right, you know what, Rich, I gotta fly to Kalamazoo at 6 in the morning, but I'm happy to stay on. Is there a course online? The courses online are brought to you through our DS3 experience. So yes, everything that we do, we have available online for our members. And again, if you want to just type in demo, someone will show you how that works at no obligation. So we have pretty much all of our material that you need available to our members, but it's not available to the non-members. Yes, Willard, if you want to just type in demo, and someone will get a hold of you tomorrow with that. I'm answering the questions as they're popping up. Rich, you still there? Did I put you to sleep with all my talking?
No, no, I'm good. You know, a lot of interest, and you know, Guy, think about how long we've been doing this, and you know, we're really starting to see a momentum shift out there. Lots and lots of dentists are wanting to kind of learn about this now. And my suggestion to you would be, I want to create a little bit of a sense of urgency. You know, if you are the first guy or gal in your community who does this, then you have a little bit up. And if you're not that first person, that doesn't mean that you can't do it and do it very, very well. So again, you got to partner with somebody. You have thousands of questions. This is a process, and that's what we do, is help dentists do this.
And lastly, I'll mention, you're going to all get the survey. I see a lot of people are still on, and that's fantastic. I mean, I don't mind staying on if you have more questions. Type them in, we'll get to them. It's been a great turnout. That being said, you will get a survey. It'll take about 3 minutes to fill out. It's worth your time just to self-assess where you are in your practice. So fill that out, and at the end, if you have more questions, you'll get the opportunity to request that one of our team get in touch with you, and you'll find our business is not real pushy. We're helpful. We're happy to help you along the way, and see where you are in dental sleep, and see if we can help you obtain your goals.
All right, excellent, Guy. Thank you so much for putting that thing together. I did provide the picture of the dog for you, so.
Yes, thank you. And we got a couple of more questions. Greg, yes, the answer is yes. Just if you're as a current member, you certainly that's a newer product that we have, the DS3 experience. So just contact us tomorrow. We'll hook you up with it. Everybody's welcome. We've got a lot of thank yous coming through, and yes, the home sleep test should be repeated if it doesn't match what it needs to be. But you know, it really comes down to a little bit more than we can talk about today. We have to have specific goals for subjective and objective results, and then we have a way of making a decision based on that. But at times we do have to repeat it. Yes, at times we do, but it really depends on what our goals of treatment are. That's a great question, John.
And you never, you know, the bed partner is a very poor evaluator of snoring. You know, if you wake up to go to the bathroom in the middle of the night and your partner's in REM sleep on his back,
right,
and he had 2 beers the night before, he's snoring. And you know, but again, those are these are part of the hundreds and hundreds of questions that you have as you get into this and you do it.
Well, I think I'm going to call it here, Rich. It's 9:24. It's one of the latest we've been on in quite some time. I'm glad that everyone tuned in. We'll be doing more of these in the future. Again, if you have other questions when you get that survey, just answer that you'd like us to contact you, and we can answer those questions. We will be addressing other dental sleep medicine challenges in the future. Hopefully, you understand how passionate all of us at the DS3 experience are at helping us to succeed in dental sleep medicine. Thanks everybody for really, honestly, it makes us feel like all this work we put in is worthwhile, that we have you know, hundreds of people in the hundreds on a webinar on a Tuesday night. So this is really it makes me feel like it's going to be worthwhile. Remind me of that when I'm up at 6 tomorrow and I haven't packed yet. All right, good night.
Thanks again,
Anything else,
guys.
Rich? All right. Bye-bye, everybody.